And a very, very happy good evening to you, America. I'm Dr. Randy Fink, and it is that time again. It's Tuesday at 5 o'clock Central Time here on the Gulf Coast, and it's time for Fertility with Fink and Friends. I am Fink, you are Friends, and I am so happy to have you here as we do every Tuesday evening at this time. 4 o'clock in the mountains, 3 o'clock on the West Coast, and 6 on the East Coast. And this is where we get together to talk about all those things that are important to us, things about making a family, things about getting pregnant, things about staying pregnant, things about generally obstetrics, gynecology, and infertility, which is what I do. My friends, that is what I do. I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and in Panama City. I also work with the Missouri Center for Reproductive Medicine, MCRM, with offices just outside St. Louis and Chesterfield, Missouri, and in Tulsa, Oklahoma. Great group of folks up there, just like down here. And if you're on the Gulf Coast today, it's 75 degrees outside, which means another beautiful day. I think it was pretty sunny out there, and all that stuff makes me happy, just like being here makes me happy, especially given what we where we are on the calendar tonight. This is Fertility Awareness Week. It is the time that we really all get together and become aware of what it means to go through this process, where we really focus on the fact that nobody who is dealing with these issues is alone. This is something that affects really 1 in 5 couples. 1 in 5 couples deals with fertility concerns. And it is so often a conversation that people aren't comfortable having. It's a conversation that really honestly is neglected. Because the numbers of folks out there who are dealing with this problem is not going down. In fact, really, it's going up. We have some wonderful people who work in this profession, nurses, providers, staff, people who are really kind of committed to helping you build your family. And so it's time to talk about it. It's time to experience it. And it's time to know that now we can really move past it. So, Infertility Awareness Week. I don't know if it's appropriate to say happy Infertility Awareness Week, but happy week anyway. I hope your weekend was great and that here you are on a Tuesday doing well. And so let's see, SB Charles, good evening. Haven't seen you for a little bit, but so happy to have you. You are number one on my Instagram feed. So we've got Instagram, my Instagram right over here, and that's Randy Fink MD. Here in the middle is some different Facebook feeds. We've got New Life Fertility, we've got MCRM, we've got LinkedIn, we've got YouTube, we've got the First Fertility Network, of which both MCRM and New Life Fertility are proud members of. Over here is New Life Fertility's Instagram page. And let's see who's joining. Let's see, SB Charles, I think you said praying that your second transfer will work. Well, we are all here with you, my friend, sharing those prayers and sharing those really positive thoughts that embryo going into you is going to be the one this time that's going to stick. Hello to the Bama gal. That is my dear mother and father in Mobile, Alabama. Not too far from where I am here on the Gulf Coast. Good evening to you, Emily and Harold. Let's see. Marlena is here. Hello, plant honeys. Hi, Rosa. Nice to see you as always. Thank you for being here. Katie Howard, good evening. And Noodles for Life. Noodles, it's always a pleasure to see you. Let's see, Angela Sapp, good to see you, my friend. It's a great that you are here, as is Zenny, my friend Zeneta in South Florida, who is a truly loyal viewer and friend here. Thank you so much for being a part of our week here. The room is brightened every time you're here. Let's see. Do you get a prize, SB Charles? I hope the prize is that you leave with that embryo. So actually, you asked for any advice, and I do have some advice. And And I have to say, it goes a little something like this. By the time folks go through so much in terms of fertility treatments, it can become very souring. It can become something where we don't know the outcomes, and I think in order to try to protect our hearts, we sometimes can start to feel negative about what we're doing. For instance, you may go in for an embryo transfer and feel very defeated, and I've seen it a million times. Just kind of be like, well, here I am again, but we're going to do this, but I'm not getting my hopes up. I'm not getting my emotions. I'm not getting my heart invested in this process because there's just a chance that it's not going to work, and I can't deal with another broken heart. And I think that's a realistic approach. I certainly understand it, but I have to tell you also that I think hope really does make a difference, and there have been studies on that. Positive vibes equal positive betas, and that's kind of the way I think about it. The beta HCG, of course, is our pregnancy test. Positive vibes mean positive betas. So my single word of advice is believe, because I think every time we do something here in terms of fertility, there is an opportunity for us to be successful. Does it work every time? Unfortunately, no, it doesn't, and that's the hard part about what we do. But the mere fact is that it can work. It has the potential to work, and you have made it this far, my friend. So go in there with that positive energy, feeling like there's nothing in the world that can stop you from getting what you want. That's my one word of advice. It's to believe. Let's see what else here. Plant Honey says AMH of 1.3. I have endometriosis and an endometrioma on the left. Is Follistim 300 units too high of a dose, along with Menopur 150 and Letrozole 7.5? In my opinion, so when we know that there's endometriosis, that endometriosis creates it creates stress on the eggs. It is what is known technically as oxidative stress, but it creates stress on the eggs. And that stress means that those eggs may be more sensitive to the FSH. Furthermore, it's hard for me to say, gosh, I'm going to criticize somebody else's protocol. But I will tell you that 300 and 150 is a pretty high dose, strong protocol. Your AMH is pretty good, Plant Honeys. I don't know how old you are. That probably has something to do with it there as well. But 300 is sometimes a little high for folks with endometriosis, because the data shows us that in most cases, stimulation doses of FSH beyond 225 rarely recruit any more eggs than you would otherwise get. So going from 225 to 300 just adds fuel to a fire that's already burning really as hot as it knows how. In other words, there are a fixed finite number of receptors, of receivers for that FSH hormone. And when you put more on them, it doesn't mean that you get better eggs. It doesn't mean that you get more eggs. It just forces the growth of what you have. And with endometriosis, where some of those eggs are going to be fragile anyway, I tend to err on the side of going a little bit lighter. So in my practice, that would be, there's always some caveats here, and that depends on, well, sort of what sort of stim have you done before, and what kind of outcomes did you get? But I'm a little leery of that. So hard to say it's too high a dose, but it is a high dose. Above 225 doesn't necessarily give you any better outcomes. Food for thought. Let's see. Hi to Sheila and to Sarah. Good evening on the New Life side there. And I see I got a bunch of people on the Facebook side, but nobody said hello yet. So hi to all you guys. This is Fink and Friends. I'm the Fink, you are the friends. And here we are at almost a quarter past the hour. We're going to be here until the top of the next hour. And by the way, at 5:30, we're going to do a very special 5:30 Fuzzies with Fink in honor of Fertility Awareness Week. So stick around. I'll be about 15 minutes here from now. Let's see here. I have SVT. SB Charles says, should that be a problem? Well, SVT is supraventricular tachycardia, for those of you who don't know. And what it means is that there is a portion of the heartbeat that is fired off from an area that is above the ventricle. The ventricle is the portion of the heart that squeezes, that makes the blood flow. SVT, supraventricular tachycardia, typically presents with a heartbeat of about 220 beats a minute. And when you have a heartbeat of 220 beats a minute, you know it, don't you, SB? Yeah, yes, you do. What happens when you have SVT? You can, there's some things that you can do to try to break that yourself. You can put your face into a bucket of ice water, believe it or not, that'll do it. You can strain, that's called the Valsalva maneuver. That can sometimes break the SVT, but sometimes you got to go to the hospital and they got to give you a little medication that makes the heart go ding, 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 and then it goes boom, and it stops, and you feel like, oh, that's a terrible feeling, and then it starts to beat again normally. That medicine's called adenosine, and that's what we use, to break it if the conservative measures don't. Now, what significance does it have? Well, if your heart's going 220 beats a minute, it can't really sustain that. That's not something that the heart muscle is designed to do. So eventually what happens is that it'll start to give out, or the pump that is the heart will start to go into failure. So it's something that does end up having to get treated. There are ways to treat it so that it doesn't come back. So some people take long-term medication. Alternatively, you can do something that's called an electrophysiology study, or EPS. And what they do is known as an ablation. They can find the specific spot in the heart muscle that's triggering that very rapid heartbeat. And when they do that, they can basically alter the heart muscle either by using heat or by using cold, and changing the electrical impulses that come from that spot. And hopefully that fixes it. So should that be a problem? Well, pregnant women who have SVT can be more predisposed to getting an event, just because as the pregnancy gets bigger and the heart rate, the blood volume that's being pumped by the heart goes up, it can lead to issues. So hopefully that means that your SVT has been dealt with before it's fixed, and you don't keep getting those SVT episodes, because if you do, I'd suggest you get that taken care of, for sure. Also, comment here, I wish I could afford your office. You can. I'll tell you that costs of IVF in this nation of ours are really higher than they need to be. And everybody's, there's a lot of folks on this podcast who have been with me since the days at my former employer, where costs are significantly lower. But the trade-off there is that in that kind of environment where there are that many patients going through the system, as you know, you don't talk to the same person twice. The nuanced level of care that you get from a more boutique type environment may be something that you don't need, but it may be something that you like. And that's one of the things that gets lost in a larger volume type practice. So in a smaller volume, the prices do go up a little bit. There are wonderful financing tools available. There are discounts. There are different kinds of payment programs. So with us, we really do try to make it easy. We really do try to make it as something that everybody has within reach. But yeah, it is a financially stressful time to have to go through these treatments and to have to pay real money for them. And I think of it as an investment in the future because sometimes this is what it takes to build our families. Now, there are places that you can go where it's $30,000 or something for an IVF cycle, and I think that is, frankly, it's asinine, it's unnecessary, it doesn't need to cost that much. And in many cases, when you go to places like that, the quality of care that you get, or even the nuanced care that you get, is really no different than what you get anyplace else. So if it were a top-notch, top-level service, then maybe there's something to that for those who want it. But at the end of the day, I just find it really hard to stomach that costs can be that high. Now, yes, we do see folks from all over these United States, both here on the Gulf Coast and in the time I spend at MCRM in St. Louis. We can see you virtually. We're happy to consult on your other cycles that you're doing someplace else. All you have to do is just look us up. Give us a call because it is something that we would love to be able to share our wisdom with you. Hi, Lauren. Thank you for being here. And Taylor is here tonight. Are there any new and easier ways to get sperm from a man who has had a vasectomy? His last procedure was really rough and had a long recovery time. So technically, the way that you get sperm from a testicle is by placing a needle into it. And usually that can be done as something that's called a TESA. And a TESA is when, and it depends on who's doing it, we numb the testicle and place a needle in and extract some sperm. And in the case of a guy who has had a vasectomy, now he is still likely making gazillions of sperm. They just have no place to go, right? Because the highway is blocked. The tubes are tied, as it were. The tube is cut, and so there's no place for that sperm to go. But they're still really hanging out there. So to get enough sperm to be able to use is usually not that difficult. Now, there are other types of procedures. Sometimes they'll do an open biopsy on a testicle where they take kind of literally a piece of the testicle and search for sperm. That is a much harder thing to recover from. It's a bigger to do. It is more commonly used in men who have sperm production problems. Yes, the same thing as an aspiration. The A stands for aspiration. And for most people, it's actually pretty well tolerated. It causes some soreness for a day or so. When you have to do the open biopsy or you have to do something more extreme, then that's when it gets to be very, very difficult. Now, I'm told that there are some urologists who don't use numbing for that procedure. And I frankly, that is not the way I would want it done, nor is it the way that I would do it. So numbing is kind of a big thing in my world. Life is too short for pain, quite frankly. Noodles asks, my FET canceled again due to the lining not progressing after suppression on estradiol and progesterone for 10 days to induce the period to restart. I tried uterine PRP. I tried Viagra, vaginal estrogen. What if my period won't come again? So Noodles for Life was on some suppressive medication. I think you were on Lupron for endometriosis. Lupron is a drug that tells the brain basically to shut down the hormonal supply, shut down the hormones, because we're trying to get estrogen taken out of the environment so that endometriosis will be turned off. So, Noodles, the first thing I'd want to know there is kind of what are your hormones doing? What are the hormone levels, the FSH and the LH, when you're not taking all the medicine? I would say, it sounds like you've done the right things. The one other piece that goes into that is sometimes we will use an injectable form of estrogen that's called estradiol valerate, or the brand name is Del Estrogen, and that's an intramuscular injection that you get every other day, and that is often has a little longer half life. It's absorbed very well. You prefer not to have to get a shot, which is why we don't use it on everybody, but um, uh, that may be the one kind of missing piece there. But I'd want to know kind of what you're doing when you're not on all the meds. What's your FSH and your LH look like? Have they recovered? Because that really is going to tell me what's going to happen with your lining as you progress sort of down the line there. She says, I don't think I respond well to estrogen for FET to build the line. My doctor doesn't think that a modified natural is better than a medicated for me. I would agree. Does it make sense? Modified versus medicated. I'm 44 years old. If you're not really building a lining, I mean, you can try. Sometimes I'll say, well, look, if you're not building it on all the estrogen we're giving you, then we'll say, we could even do a mock cycle with some ovulation induction and just see if you build that lining yourself. And if you do, then you do a transfer. And if you don't, then say, okay, well, your natural estrogen isn't doing any better. But again, I'd want to know what's going on with your hormones there, sister. And how has your pituitary gland recovered from that lupron suppression? And that is through FSH and LH. That's how we would know that. Rosa says 5 months postpartum. Has it only been 5 months, Rosa? Golly gee. 5 months postpartum and breastfeeding. I have some bleeding, which I think could be a period. Is it possible while breastfeeding? The answer is yes. So, when you breastfeed, it has a suppressive effect on ovulation for really about 6 months. And after that 6th month, it stops being so effective as a method really of preventing pregnancy and just in general of preventing you ovulating. So you could definitely be having a period. And there's some women, I'll say that, as long as they breastfeed, they may not get a period at all, but still there are others who after 6 months or so will just kind of start having a period on their own. So that's often the time that I kind of start to think that it is more probable that the period is on the way. So I think that may be what you're in for. A little adenomyosis. Any advice before an embryo transfer? So adenomyosis is the process where the glandular lining of the uterus, and that glandular lining is normally what sloughs off or out the door when you have a period. Instead of going out the door, it starts to take a dive into the muscle of the uterus. It's going down into the muscle. And that's what adenomyosis is. And adenomyosis may not be something that is always pathological. In other words, it may not be abnormal. It is in many folks, especially folks who have had children before, and certainly by the time we're at least in our 40s, sometimes even in the 30s, it becomes really a kind of a normal variant. So I wouldn't say that it's necessarily a problem. If we think that it may be a problem, it can be potentially suppressed in many ways, like endometriosis is, either with Lupron or with Orilissa. But just because it's there doesn't mean that it's a problem. So, life that too, life is too short, too many things to worry about. And just because you had something that looked like adenomyosis doesn't mean that it's got to be a problem for you. Jennifer is here. Good evening. How long should you be off L-arginine before an egg retrieval? I've heard that it is bad for egg quality. You heard exactly correct. So L-arginine is an amino acid that ultimately helps the body make what's known as nitric acid, which increases blood flow. So that's a good thing to be on when you're talking about having an embryo transfer. In fact, it is one of the recommended supplements, part of the 6 or so that are recommended before embryo transfer. Those 6 supplements for embryo transfer: prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. All right, because we're increasing blood flow to the lining, which means that lining grows up better, it becomes thicker, it makes for just a better, warmer, nice, spongy, warm, juicy place for an embryo to implant. How long should you be off? Well, so what happens, the reason that L-arginine is not a supplement that I recommend for egg quality is because there are studies that show that it can cause a chaotic kind of growth of eggs. It can cause eggs to not divide properly. It can sort of destabilize those eggs. And I would say realistically, probably, I don't know that we know that answer definitively, Jennifer, but I would say about a month. I'd say at least a month. It's not, because it's an amino acid that is in your body itself. I think that, there's nothing to say, oh, you got to be off of it for 3 months or something to get it out of the ovary, because it doesn't, it's already in the ovary. It's part of what's floating around in our bloodstream. But as far as a supplement goes, I think being off of it a month before starting a stimulation is probably a reasonable thing. And that's a great question, because I have seen fertility supplements that contain L-arginine, and there is no question about the research, about the data that shows that L-arginine really is not something that is helpful for egg quality, but in fact may even be damaging. Lamu Hair, good evening to you. And Shada says, hi Shada, can you do modified natural embryo transfer after being on Lupron for 3 months, or you'll be menopaused after that? Well, so you can. So if you've been on Lupron to shut down endometriosis, you can do a modified natural afterwards, but sometimes that suppression is still hanging around. And if it's still hanging around, it may be a little bit more difficult to get the body to respond to the letrozole and to make those hormones that you need in order to build that uterine lining, and in order to build up that egg that's going to get ovulated in order to make your progesterone. So in my opinion, I have, and in my experience, I've just found it easier for folks to do a medicated or a programmed cycle after coming off suppression, just because we can be more precise with the medication, and we really know how much medication to give you and how your body is going to respond to that, rather than asking your body to do its own natural thing after we've had the plug pulled out on that hormone generator from the Lupron. So I do think a little bit easier to do a medicated cycle than it is to do a modified natural after Lupron. Good evening, Angela. Thank you for being here, doctor. Let's see, who else we have? Amber Jones. Hi, Amber, in the beautiful shores of the Gulf. I got my friend Daisy from Miami here. Hi, New York baby DJ. Daisy is an old friend also. Appreciate you being here tonight, and hugs and kisses to the family. Hi, Indopino Journey. Nice to see you guys. Long time no see. Nessa, wow, Nessa's here. That's a shock. Good to see you there, my friend. Hi, Alicia. And let's see here. Nessa said, if you did an egg retrieval at the age of 34 and then later at the age of 36, would the embryos you have from 2 years ago be better or less quality when compared to the egg retrieval you did now? So in general, the earlier you are, the younger you are when you get your eggs, the better, or the greater the probability that those eggs are going to be normal. Now, is there a huge difference between 34 and 36? And I would say, no, it's not a huge difference, but there is a difference. So I would expect that the rate of euploid or chromosomally normal embryos that resulted from an egg retrieval at 34 should be a little bit higher than those at 36. A little bit, not dramatically. Now, if you're talking about 24 versus 34, probably a lot higher. You're a lot better at that age. But yeah, so a little bit of a difference there, Nessa, for sure. Good evening, Logan, the therapist in Northwest Arkansas. One of the finest therapists I know. So reach out to Logan. If you need it. And speaking of which, you know what? It's half past the hour, so it's time for the 5:30 Fuzzies with Fink, and we have a special interest here, and that is in honor of Fertility Awareness Week. And they got me this shirt. It's actually a nice T-shirt. It's very colorful. It's a little autumn looking, right? I think it looks a little Halloweeny, and it says support. Well, when I read it, it said support squid. Support squid. And I'm like, I support squid, but I don't get it. It's the support squad, and I think that is the crux. The squad, not the squid. I think that is the crux of what we're talking about when we're talking about Fertility Awareness Week. This is a lonely process. It's a process that can make people feel very much ashamed of their past, like maybe they've made mistakes in the past that they're worried about, that they can't stop thinking about. It's something that causes immense anxiety, worries about the future and the unknown, not knowing what the outcome is going to be here, wanting something so badly and having it just right at the tip of your fingers, but you can't quite grasp it. Needing to deal with the financial stress of going through this treatment, the emotional and the physical stress of going through these treatments. The important thing to know is that you are not alone. More so than any other time this year during Fertility Awareness Week, we want to call attention to the plight of everyone who wants a family but feels like having a baby is just out of reach. It's time to grab that and pull it close to your heart, because you can do this. Each and every one of us has the capacity to achieve whatever it is we can dream. And as we celebrate all of the people out there who need our support tonight and this week with Fertility Awareness, the Fuzzies with Fink is the opportunity for us all to say, you are not in this alone. We are all in this together. And so let us stand together as one community and send out all the positive vibes we can tonight to everyone who needs it. To all those people who feel frightened, who feel alone, to all those people who just aren't sure what to do next. And maybe it's not just about fertility. Maybe it's about family. Maybe it's about relationships. Maybe it's about school. Maybe it's about work. Maybe it's just about life. You know what? It doesn't have to be about anything at all. But to know that other people are there with you, people who would support you, have their hand on your shoulder, and be a shoulder for you to cry on if you need it, is sometimes one of the most important things that we can know. And one of the most important things that we can do for each other is to be there for another person in that time of need. So let's break the internet tonight with kindness, with the knowledge that tomorrow is a new day and it's full of all new adventures. And that, my friends, is the 5:30 Fuzzies with Fink. Thank you for being a part of that. If you just joined, it's about 36 minutes after the hour, and my name is Dr. Randy Fink. I'm in Pensacola, Florida, at New Life Fertility, and I also work with the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. We are happy to talk with you anytime, so give us a call and tell us how we can help. Hi, Holiday Homemaker. Oh, and Noodle said, yeah, I did have the Del estrogen and also the patches. Yeah, so I want to know what else is going on. I'd stop your medicine. Let's see what your hormones are actually doing without all that stuff. Now, that's a frustrating thing there, my friend, because you want to be pregnant right now. You want a solution now. You don't want to wait another month. You want to know it right now. But I would say, listen, that time is going to be well spent because it's going to give you a lot more information. I think it really will. Let's see. And here we go. Baseline FSH is 14 and the LH is 4, but that was no Mincy's baseline after Provera to induce the period, but the Mincy's never started after 2 weeks. So that FSH is starting to get a little higher. So that's telling me that that you are kind of perimenopausal. And that your pituitary gland is working a lot harder to try to get your ovaries to make your estrogen. So I'd want to know, what is your estradiol? I still think, Noodles, that given a little bit of time, maybe without doing something, that business is all going to reset and your lining is going to start to grow back. But that is one of the more frustrating problems that we have, and that's when trying to get that endometrium to grow and it just doesn't want to cooperate. Yeah, that's a tough. Amal, good evening to you. My doctor canceled my embryo transfer cycle on my second visit. He said I already ovulated, and she sent some labs here. Your progesterone was 9.84. Yep, that means that you released an egg. So, most of the time when we cycle, a menstrual cycle, it's usually pretty predictable. And for most people, that means that, if you have a 28-day cycle, that means that 14 days are the first part of the cycle, then you release your egg, and the other 14 days are the luteal phase, the second half of the cycle. But sometimes, especially as we mature, the cycle becomes less predictable, and we may ovulate, at the wrong time. So it sounds like, Amal, you were going to be doing you were trying to do a natural cycle or a modified natural cycle, and what happens is that as you've ovulated and that progesterone goes up. Well, actually, I take that back. I mean, you may have broken through your medication, and it just depends on whether you were on some progesterone at that time, because you could convert that potentially to a modified or to a natural cycle if you hadn't started progesterone yet. But yeah, that can happen sometimes. We get some of that breakthrough and some more of that irregularity in terms of timing as we mature. Lori, some good evening. Oh, and Stephanie is here from Oklahoma. Good evening to you. Let's see. Amber says we did PGT testing and we also chose the gender of our baby. The OBGYN told us that she was able to choose eye color when she did testing about 20 years ago. Is that true? Not that I've ever heard of. That's not even something that we really can do reliably right now. So 20 years ago, no way. I'm not sure what really she was, what she's talking about there. But kind of funny that your doctor told you that. I'd like to know more. Hi, Andre, and it's great to see you this evening here as well. Yeah, and Lo, we're talking about the effects of having to deal with all that stress, and Logan, the therapist, says, yeah, it really does. It completely takes over the nervous system, and not in a good way. We start to react to that anxiety. The portion of our brain that's monitoring for danger becomes, we stop being able to think about it, and it ratchets up our nervous system, and that's fight or flight. We're still waiting for that bear to jump out from behind the tree, or the going back to our ancestral days, the saber-toothed tiger to leap at us from the tree line. We never stop monitoring for that danger, and that danger may not be real. It may be a figment of our imaginations. Let's see here. Nessa said, we only got 3 euploid embryos at age 34. I have endometriosis and diminished ovarian reserve. I've been on supplements for 5 months. Do I still have a chance to get more euploid embryos? And the answer is, oh yeah, you do. You got 3 euploids at 34. You may do just exactly the same there. So really the biggest question is, it kind of is going to have to do with I try to be very nuanced with stimulation protocols and try to make those individualized for people so that they physiologically make sense. And the goal there is to not overstress the ovaries, but rather to gently coax the ovaries to give us eggs. Now, what we can't change, Nessa, is we can't change how many normal eggs are there, to the extent that, well, you're taking the supplements, and that's definitely a good thing. So our bodies really do have pretty robust DNA repair mechanisms. And so we may have the ability to fix that by filling our tanks with those supplements that are on the list, and especially for diminished ovarian reserve folks. Yep, and I do believe in that. I believe in it enough that I wrote a book on it. You can get a link to that. It's called The Vitamin Victory. On my Instagram page, there is a link for how you can pick that up. It's a nice ebook. It's doesn't cost a lot of money, $7.99, I think it is, and you get a coupon there that'll probably save you about $40 on the supplements in it. So, well worth it there, I think. Yeah, so there is evidence that shows us that taking a handful of vitamins really can make a difference in the outcomes. But short of that, there is no magic to it. There's no medication that we can take that has been shown consistently to fix those that age-damaged DNA. So what your ovary is going to give us has to do with what's in your ovary, and those doggone eggs have been there, since the day you were born. In fact, since you were in utero, those eggs were there. So depending on the stimulation and depending on the AMH and on your follicle count, that antral follicle count, we can sort of make an estimate of what we think that we're going to get. What we think, how many eggs do we think we can get, and based on that, we can sort of try to figure out, well, what's the odds that you're going to get euploid eggs from that. As I said, the difference between 34 and 36 is not dramatic. But it's subtle. It's there. You got 3 euploid before. I expect for sure you'll probably make, God willing, maybe you'll make the same. But certainly, hopefully, at least 1 there. Again, it just kind of depends on how many eggs you're able to get. The more eggs you get, probably the greater the opportunity that your body will give us a normal egg that will make a euploid embryo. But that's not always true. That's not always true. So you would think, gosh, if that were true, if we just give you more and more and more medication, if we just increase the doses of stimulation, then we should get progressively more and more eggs every time. So everybody who's doing IVF ought to be on maximum doses of medication. And that's not the case, because too much medication overstresses the eggs. And creates an environment where things hormonally start to happen that maybe we don't want to start happening. Plus, again, eggs can only take so much stimulation. More of it doesn't make the fire burn hotter. The fire is the fire. Hi, Janelle and Reed. Hey to Lisa. Reed asks, at what point should we look at Receptiva or other testing prior to transfer? So Receptiva is a test that looks to see if you're expressing a protein that is associated with endometriosis. It is not recommended in the general population that we should just test to see if you have endometriosis, because the mere presence of endometriosis does not mean that you won't necessarily be able to implant an embryo. And I'll tell you what I'm talking about there. And maybe you've heard me, kind of tell this story before. When I would do kind of, when I was a general OBGYN, maybe I would have somebody who was, 42 years old, and she came in because she wanted a tubal ligation. She wanted her tubes tied because she's had 4 kids. She doesn't want any more. She doesn't want to take birth control, doesn't want an IUD. She wants her tubes tied. Okay, fair enough. And we put the scope in through the belly button, going to do that surgery. And what do we find there? Oh my heavens, she's absolutely loaded with endometriosis. There's so much endometriosis there. I say to myself, oh my Lord, how does she live her life? Isn't she in pain all the time? And she's had 4 children here. So what the heck is going on? But then again, you can go do a laparoscopy for somebody maybe who is debilitated by pain with her periods, like literally debilitated. And you go in and you find one tiny spot of endometriosis and you say, how does this make any sense? And the answer there is that what you see is not what you get with endometriosis. And so the mere presence of endometriosis doesn't necessarily mean that you're going to have problems. So I don't advocate that people do Receptiva preemptively unless I have a strong clinical suspicion that they may have endometriosis and that they have had a hard time getting pregnant thus far. In that situation, you do that biopsy. It's at a specific time during the cycle, usually about 10 days or so after you've ovulated, because that's the time at which you would otherwise be implanting an embryo, right? So you want to know if you're expressing that protein at embryo implantation time, because that's when it matters the most. Classically, we use the Receptiva test for people who should have been getting pregnant but aren't. So, for example, you have repeated repeated embryo transfers, and they're not sticking. And we say, what's going on here? Because they should be sticking. Well, that's a time when maybe we go looking for endometriosis that used to require a surgery to diagnose. Well, now we can diagnose it in the office with a simple little biopsy there. That's when I kind of think about going to look for it. But if you are prior to doing your first embryo transfer, you haven't been unsuccessful with anything, you've made some embryos, though I know it's scary, it's a leap of faith, right? To stick your neck out there and say, I'm going to put this embryo in and just hope that everything works. That is, in fact, the right thing to do. The evidence shows us that most of the time it does. When it doesn't, then you go looking for things, but that it doesn't make sense to necessarily have to go looking for things without the reason. There's not other specific testing that has to get done other than I do recommend that your uterine cavity be evaluated at least once a year. And that's with either a hysteroscopy or a saline sonogram to know that there's nothing on the inside that's going to be trying to prevent your pregnancy from implanting. Amber says, yeah, maybe they just told her. And so that was about, that the doctor said, oh yeah, 20 years ago, they were able to select the baby's eye color. I'd have been like, hey, the baby's born and look, yeah, blue eyes, just that's what we gave you. We gave you the blue-eyed baby. Yeah, maybe so. You know what I used to do is that I would say, at the first OB visit, first prenatal visit, I'd say, oh, you are definitely having a boy. And then I would write in the chart, girl. And they'd say, really? Oh, yeah, definitely. It's definitely a boy. And then, at 17, 20 weeks, when they do their anatomy ultrasound, they come back and they say, you told me it was a boy and it's a girl. And I say, oh, no, you misunderstood. See, I wrote down right here. It says girl. See, these are the secrets your OB doesn't want you to know. I'm just kidding about that. That's not true. Chris and Lena, good evening to you. How long after a failed frozen transfer can you try another? The very next cycle, friends. So when you do something like IVF and you do a retrieval, then we know that stacking your retrievals, doing back-to-back retrievals, typically will improve things like your egg quality. And so that's a good thing. That's what we're looking for, right? But there is no harm to doing back-to-back embryo transfers, nor is there any necessarily benefit to it. It neither helps nor hurts. You don't need any time off if you did a transfer and you simply didn't get a positive pregnancy test. Now, Chris and Lena, if you do an embryo transfer and you get a positive pregnancy test, and then something tragic happens and you lose the pregnancy, then I say, I like you to have a normal period before you go to do another transfer. But if it was an unsuccessful embryo transfer, you can do a transfer that very next cycle. And sometimes it's better to do that because it makes you feel like you're just getting back on the horse, that you're really moving in an affirmative or a positive direction towards achieving your goal of being pregnant. Now, there are other occasions when, gosh, it's such a thing, that it's just been so trying on you, both physically, emotionally, financially, that you want to take a break. And you take all the time that you need, because it's not going to harm you to take a break if you want to take a break. The good news there is that, the uterus doesn't mature at the same rate that the ovaries do. The ovaries age much faster. So as long as you've got your embryos, those embryos came from eggs that you were as young as you could have been when you got them, even if that was just this year, they've stopped in time now. And their ability to get you pregnant is really predicated upon how old you were when those eggs came out. So, you take all the time you need, but you can jump right back in if you feel up to it. And that really is the question. Do you feel up to it? Let's see what else. Baseball games for Logan. Thanks for doing these. My pleasure, Logan. Thank you for being here. Nessa says, I can't take sirolimus. I have 19 follicles on 417, so that's pretty good. I don't think sirolimus would necessarily be something that was helpful for you, Nessa, because you got a goodly number of euploid embryos. You're 36 now. You're not 42. Doesn't sound like with that many follicles that you have a diminished ovarian reserve. So I would not necessarily recommend sirolimus. I don't know that really it would help you. Just like Omnitrope, I'm not sure that really would serve you any benefit. There's no evidence to show that it would. I think that you are probably set up pretty well right there to do good, to do well. Let's see. SB Charles asking about adenomyosis. I think we mentioned that. Nothing else to do. She says, my uterine cavity is perfect and I'm still not successful. So, it often comes back to issues about the embryo. And even with a euploid embryo, a chromosomally normal embryo or a euploid embryo gives us the highest probability of pregnancy that we have. And on average, that's about 65% probability of pregnancy. But 65% is unfortunately not 100%. What it tells us is that we know, or at least we believe, that the chromosomes are normal. Now, remember, how do they do PGT? And what are they doing there with that? You've got your embryo. You've got your baby parts here on the inside, and the cells around the outside are the part that will become the placenta. And so we take a little sample of the few cells from the part that becomes the placenta. That's known as the trophectoderm of the embryo. A few cells from the placenta, and we send those off. Now, what we're assuming there is that the cells in the placenta have the same genetics as the cells in the embryo or the baby parts themselves. And that is not always true. There is a high degree of what we'll call concordance, meaning to say that what's in the placenta is the same thing that's in the embryo itself, but not always. And that's why there's a rate of both false positive and false negative with PGT. Fortunately, it's pretty good testing, and frankly, it's the best that we have. But even if all the chromosomes are normal, there are still, millions of little chemical reactions that are happening every moment in any given cellular system. And if, like an embryo, and if any one of those little equations goes wrong, then that embryo may stop growing. So there are more things to it than just the chromosomes themselves. It's how that embryo functions, and that is a that's unfortunately, one of the faults of being human is that we can't make perfection. Unless, of course, you're talking about my children. Oh, you know what? None of them are watching tonight, so I don't have to. I don't even have to go there. I'm just kidding about that. You can't make perfection, and that's why 65% is not 100%, but it is the best that we have. Does Oralissa suppression? Hey, nice to see you. Is that? I always have a hard time with your name. Z, nice to see you, Z. Does Oralissa suppression speed up time to menopause down the line? The answer is no. And that actually begs another question that some people ask, and that is, well, if I do IVF now, or if I do some kind of fertility treatment and I, make 2 eggs or release 2 eggs instead of 1, or I go do an egg retrieval and I get, 15 eggs. Does that mean I'm going to get to menopause sooner? Am I going to run out of eggs sooner? And the answer is no, because think about it. Every single month, if you ovulate, you release 1 egg. There are millions of eggs in your ovaries. So over the course of a year, assuming that you had regular periods the whole time, you released 12 eggs, and that's 12 out of a million. Do you think that was even a drop in the bucket? No. So even if we got 40 eggs from you, and frankly, I'm going to tell you 40 eggs is too many, then you're getting quantity over quality. But even if you got 40 eggs, for that matter, even if you got 100 eggs, and the most I've ever gotten from somebody is 120, actually, believe it or not, that's not going to get you any closer to menopause, because it's still just a drop in the bucket compared to the millions that you already have. So by the same token, if you're on birth control, birth control serves the purpose of stopping you from ovulating. And so if you don't ovulate, does that mean that you keep more eggs and then you're going to go through menopause later? Nope, because those eggs will start to, kind of diminish over time just due to the process of aging alone, whether they are released or not. So Oralissa suppression, just like Lupron, just sort of turns off the hormones for a little bit, stops the ovaries from functioning. It stops the pituitary gland from making the ovaries function, but it comes back and you kind of go on about your business. The loss of eggs due to aging happens whether the ovaries are switched on or switched off at that time. We do not believe that it accelerates the ovarian aging process, but that is actually a really good question. Folks, we are going to be running out of time tonight, but it has been such a pleasure to be with you here. Please remember Fertility Awareness Week. Talk to people about it. Let people know what you're going through. And please don't be alone. I'm back here every Tuesday at 5 o'clock Central Time here on the Gulf Coast, 4 o'clock in the mountains, 3 on the west, and 6 on the east. I am at New Life Fertility in Pensacola, Florida, Panama City, and Mobile, Alabama, as well as the Missouri Center for Reproductive Medicine in Chesterfield, Missouri, and Tulsa, Oklahoma. Oh my gosh, this fertility business is not the book of your life. It's just a chapter. And what are we doing, folks? We are trying to rewrite that chapter together. Every step forward with love, every step forward with kindness. The world is not a kind enough place, but most importantly, every step forward with hope. Because tomorrow is a new day, and God knows it's full of all new adventures. My one word of advice is believe. So until next week, I'm Dr. Randy Fink. Thanks so much for being here, and good night.